When we think about pre-excitation, I want you to think about something is getting excited early, and that's going to be the ventricles. It's causing those ventricles to depolarize earlier than when they should normally depolarize. So Wolff, Parkinson, White. We mentioned that when we talked about a specific SVT, which is called AVRT, atrial reentry tachycardia, which means that Wolff, Parkinson, White, if it is associated with a tachycardia, causes re-entrant tachycardia. But Wolff, Parkinson, White can occur completely independent of tachycardia. So there's a lot of people that have Wolff, Parkinson, White, they're not running around with AVRT. Okay, it's only if that time frame that goes into this re-entrant circuit that causes that tachycardia that they're going to come in with SVT. Now, someone that has Wolff, Parkinson, White, can they have these intermittent episodes of SVT or AVRT? Certainly they can, and sometimes their body will go in and out of it. So sometimes it will seek help, and sometimes they won't. Sometimes if they will last a few minutes, they will just like, oh, I don't know, I just get these intermittent episodes of palpitation. They last for a few minutes, and then they go away. But the key is to try to identify, what's causing that SVT. And sometimes that rate is so fast, we can't see this classic abnormalities that we're going to see with Wolff, Parkinson, White. WPW is an accessory pathway that we're going to see between the atria and the ventricles. It can be on the left side, between the left and right, left atria and left ventricle, or on the right side, between the right atria and the right ventricles. When we have WPW, we still have initial depolarization that's coming from the SA node. We're going to know that by looking at our ECG, and on our ECG, we're going to see an upright P in lead 2, and we're going to see a downgoing P in lead AVR. So we still have depolarization that starts from the SA node down to the AV node. When we get down to that AV node, we're going to have depolarization that goes through that AV node and down to the ventricle. Okay? But at the same time, when that SA node fires, that SA node is sending depolarizations down through this accessory pathway. Think of it as a superhighway. So it's just an open area. We don't have that delay from that we're going to get from the AV node. We just have depolarizations that are going right down to the ventricle. When we have that depolarization that goes right down to the ventricle, we're going to have a mismatch of ventricular depolarization. We talked a little about this last week. So if the ventricles are not depolarizing at the same time, how is that going to affect our QRS? It's going to be a wider QRS. Okay? So we're going to have a wide QRS. The other thing to think about, okay, is if we're bypassing the AV node for some of these depolarization, what on our ECG represents AV node and the depolarization that's occurring at the AV node? PR segment. PR segment. So part of our depolarizations are going through the AV node, but we have early depolarization of those ventricles, which is going to kind of cover up most of that PR segment. So what we're going to see initially is kind of give us our indication that there's something awry. We're going to see that wide QRS. We're also going to see that PR segment is shortened. We may have a PR interval, is really how we look at this. Our PR interval is going to be shorter than normal. So we've got that discrepancy in our depolarization of our ventricles. We've got that PR interval, or that PR segment that's going to be a little bit shorter than normal. And the other thing that we're going to see is normally when we have ventricular depolarization, it occurs at the same time, right and left ventricles. And so we have this sharp upswing of our R, we have that sharp downswing of our R. But because now we're having a difference in the time for depolarization, our upswing of that R is kind of wonky. Sometimes it'll look really squiggly, sometimes it'll look concave, sometimes it'll look convex. So concave kind of comes in a little bit, sometimes it goes out, and sometimes when you look real close, it looks wonky. And that's just an indication that depolarization is not occurring in a normal fashion. It is still occurring, but it's not occurring in a normal fashion. So again, normally we would see a sharp upswing like we see with this red line, but when we have Wolff, reference in white, when we have this difference in our depolarization of the ventricles, now we're going to see here it's a little bit sunken in, so a little bit concave as it comes in. And look, we have the NEPR segment, so if we measure our PR interval from here to here, our PR interval would be shortened. So those are the three main things you're going to see. Okay, we're going to see a shortened PR interval, PR segment area. Okay, we're going to see a wide complex QRS, and we're going to see that wonkiness of the R wave on the upswing. That wonkiness is called a delta wave. So we call it delta wave. Again, we have type A and type B. Type A is associated with a left-sided accessory pathway, and type B is associated with a right-sided accessory pathway. Now, both of these, we're still going to have that short PR interval. Both of them are short PR interval. Both of them are still going to have a delta wave. Okay? Both of them are still going to have a wide QRS. The difference that you're going to see between this type A and type B has to do with our chest leads, our precordial leads. Okay? In our type A, our left-sided pathway, we are going to see prominent R waves in V1. If you think back to how our R to S progression should be for our precordial leads, and you might recall that normally in our V1, we have a very short R wave, so very low amplitude R wave, and a much more prominent S wave. V2, a little bit higher amplitude R wave, still a more prominent S wave. And then around V3, V4, we're going to start to transition to a more prominent R wave and less prominent S wave. And but here in this type A, this left-sided, we have a prominent R wave, big, tall R waves, maybe a little bit of S waves. So big, tall R waves. That's opposite of what we would think. So that, again, is kind of a clue. Like, why do I have prominent R waves in my V1? I shouldn't have. What would be the causes? And you've got to have a differential for those causes. Prominent R wave, okay? And then we can also see T wave inversions. The prominent R wave and T wave inversions. Normally, our T wave is upright. Okay, normally our T wave is upright. When we have this WPW, okay, on this left side, we have T wave inversions with that prominent R wave. Okay? On our right side, here our V1 looks okay. V1, V2, we have a small R wave, prominent S, small R wave, prominent S. So our progression is okay, but what we see on this left-sided pathway is we are going to still see that delta wave, but we're going to see T wave inversions now more in those lateral leads. V4, V5, V6 area, we're going to see T wave inversion. That's how you differentiate between your type A and your type B. The key about WPW is identifying the delta wave. Identify, because there are other things that cause a wide complex QRS. And there are other things that can do that. There's other things that can cause a shortened PR interval. Okay? But when you combine and you look, wait, I've got a shortened PR interval, plus I have a wide QRS, that should be your clue. You need to really look at that QRS complex to figure out if it's going straight up and straight down, or if we have that delta wave that's in there. So this is an ECG of WPW. Okay. We've got the wide QRS. If we look down at the bottom, we can count about 3 boxes. Okay. Even when you look down at this strip at the bottom, okay, as you're looking, you can see, looks like pretty regular. Okay. When you look at our QRS, it looks like a wider QRS, right about 3 boxes. We have P's that are associated with our QRS complexes. Okay. We can look up at our ST segments as well. And then when we go back down to our intervals, you can see that this P is pretty much right on top of that QRS complex. That's not normal. We should have a little bit of space between our P and our QRS complex. We have that PR segment where we have that slight delay between atrial and ventricular depolarization. But here our P's are right up on top of there, so that gives you an indication that we have a shortened PR. And then if we look really close at this, look at that. Look at how that, and that's coming directly from this ECG, but look at how that R wave goes up. the arteries look super wonky as it's going up. Now, this is more obvious WPW. A lot of times they're not that obvious, and you have to have a good clinical gestalt. When you see that short PR, and you see that wide QRS, this has to be in your differential, because these patients can die from this cardiac anomaly, especially when they go into a supracapacitor arrhythmia. But we can see here that it kind of comes up and then down a little bit, more convex, concave, and then we finally up and then straight down. So it's really just that upswing of that R wave that we're going to see this delta wave. And then here's another lead in the same ECG. Again, not quite as obvious, but we have that short PR interval. We've got that wide QRS, so that means we're going to look at that anterior portion of the upswing of that R wave, and here it comes up, but then it kind of goes a little bit convex, and then goes all the way up and then straight down. That is your WPW delta wave that you're going to see. The next accessory pathway or pre-excitation syndrome associated with accessory pathway is Lone-Gangnon-Levine. Now this is pretty rare, so you're probably not going to see this very often. But here we have an accessory pathway, but the accessory pathway here is called the bundle of James, or the James bundle, and it's actually an accessory pathway that is bypassing the AV node. Bypassing the AV node. Well, that's significant, right? Because we need that AV node to help us have a little bit of space between the atria and the ventricles, the depolarization. But here, this accessory pathway is bypassing the AV node, which is not a big deal if your heart rate's 60 or 70 or 80, right? That's not a big deal. But what if the patient's in an atrial flutter, and now you've got atrial rates of 300 to 400? We are relying on that AV node to block the majority of those atrial depolarizations down to the ventricles. But if we have this super highway that's bypassing the AV node, we've got a problem. Now we've got ventricular rates in the 300 or 400s, and that's not sustainable. Okay? So what we're going to see for this, okay, when we look at this, because the ventricles are still depolarizing normally, all we're doing is bypassing the AV node. And once we bypass the AV node, we've got that ventricular depolarization that's going down the electrical conduction pathway normally. So our QRS complexes are going to look normal because we have normal depolarization of the QRS pathway. We don't have a delay in the depolarization of one ventricle versus another. Okay? But because we have this accessory pathway, we're bypassing the AV node, we're going to have that short PR interval. We're not going to see that delay at the AV node like we're going to see with our PR segments. So short PR interval. Okay? And again, think about the depolarization of those ventricles. It's depolarizing normally. So we're not going to have a delta wave. So all we're going to see here really is a short PR interval. So when you see a PR interval that's shortened, this needs to be on your list of differentials. And these patients are often going to be younger patients, okay? But it really depends, right? If someone comes in and they never go see the doctor, this may be something that is diagnosed later. Again, signs and symptoms, they may complain of palpitations, they may have dizziness, may have syncope. It's all associated with their heart rate. Okay? Depending on what their heart rate is will depend on what their signs and symptoms are. If I was a betting person, I would bet that you need to know WPW more than you need to know LGL. Okay? Because you're going to see WPW, but you're going to miss it. You're going to miss it because you're not going to have that on your differential. You need to have that. All right. The other thing we're talking about is Brugada. Brugada is really important that you know Brugada because Brugada accounts for about 4% of sudden cardiac death. Okay? Oftentimes, these patients will come in with lightheaded, dizziness, palpitations, maybe a syncopal episode. Anytime you have young people that come in after a syncopal episode, you must ask about a history, family history of anybody that died when they were maybe 20s, 30s, 40s, sudden cardiac death, and there was no identifiable cause specifically. sometimes, especially nowadays, oh yeah, I do have a family history of someone dying, and they said they had some weird heart condition. We don't know what it was. Right? It's probably this. Nowadays, we can see this in people even up into their 60s. But ideally, typically, we're going to see this in 20s to 40-year-olds. It's oftentimes can be associated with genetics, but it also can be associated with medications like TCAs or sodium channel blockers. Cocaine rears its ugly head again as a cause of Brugada syndrome. Many of these patients have no idea they have it. I've seen Brugada probably a half a dozen times on patients that came in with suicidal ideations. If you come into the ER and you've got SI, you've got to have this whole medical workup with labs and EKG and get medically cleared. And so I've seen about a half a dozen of these patients that were in basic training or AIT and had no idea that they had this. And we caught it on their kind of a screening EKG for SI. So many of these patients asymptomatic. If they do have symptoms, again, think about palpitations, think about dizziness, and then we're going to ask about the history of sudden cardiac death. On EKG, the first thing we're looking for is something called the right bundle. We'll talk about bundle branches in a minute. The right bundle, and we're looking for evidence of ST elevation, and oftentimes we're going to see it primarily in V1 and V2. So ST elevation meaning J point elevation, okay, in V1 and V2. Most of the time, these patients, now, if someone comes in and they're 55 years old and they're clutching their chest and they have chest pain, and we see J point elevation in V1, V2, we're going to assume this is an MI. Okay? But these are patients that are probably not coming in like that. They're either coming in because they felt a little weak and dizzy or had some palpitations, and you're doing this ECG, and we're going to look for that J point elevation in this patient. And there's something called a coved appearance. And this is what a coved appearance looks like. So it comes up and it comes down, and then we have this T-wave inversion. This is a coved appearance. It looks like a tall hill that you would love to, ice skate down, or maybe not ice skate down, that sounds dangerous. Maybe a toboggan, maybe Michigan toboggans, or even just like a sled or something. That'd be fun to sled down, I think. Okay, so we have this big cove pattern. What we're looking for, we have 3 types of Brugada. We're going to focus on the one that is specific for Brugada. The other ones are suggested of Brugada. And so you can learn about those on your own, but really this is what we want to think about for Brugada. Type 1, we're going to look for RR prime. Now, it may be in the form of RSR prime, but either way you're going to have 2 R waves. You might have an S wave snuck in there, but either way you're going to have 2 R waves. And because 2 R waves is the classic appearance of right bundle branch block. So if you see something where you have 2 R waves, especially if we see it V1, V2, maybe even down to V3, sometimes in V4, that is like, okay, wait a minute, why am I seeing this in otherwise young, healthy people? Okay, if we have this elevation, so 2 millimeters elevation in V1, V2, again, this has to be context. Okay, this is otherwise young, healthy people that don't have a bunch of coronary artery disease, hypertension, or ACS risk factors. Okay, and then we come up with that cove pattern, with that J point elevation, and then it brings us down to a negative T wave or T wave inversion. This is what we'll see for Brugada. This is an ECG of Brugada. Now, if you look at the bottom this bottom rhythm strip, this 10-second rhythm strip, we can say looks fairly regular. It's actually a little tiny bit tachycardic of just over 100. But our R to R waves look okay. We've got P's and QRS's, that looks okay. Okay, we can come up and then look for our ST segments. And when we come up to look for our ST segments, we do our likes with likes. So 1, AVL, B5, and B6. We look at B5 and B6 and then just kind of make a note that it looks like maybe we've got a little bit of J point depression or ST depression in B5 and B6. Okay, so we're going to keep that in mind. 2, 3 in AVF, maybe even a little bit of J point depression in our inferior leads. So we got lateral and inferior leads, a little bit of J point depression or ST depression. Okay, look at V1, V2. That's going to be looking at the, do you remember what part of the heart the V1 and V2 looks like? Septum. Okay. And so if we look here, we can say, well, yeah, we have this R wave that comes up, we've got an S, and then we've got another R wave. Okay, well that's a little bit concerning because we normally shouldn't come back up above baseline. Certainly a little R wave and a big prominent S wave, that's normal, but we shouldn't come back up above baseline. So we know we have an R prime here, really technically we consider R as R prime. And then we have that elevation of that J point, and we come down back below baseline, we have that T wave inversion. Look at V2. Right, V2 up, down, back up, and if we think this is our baseline, we've got about 2.5 millimeters of ST elevation here, and then we come back down below our baseline with those big cove segments and that T wave inversion before we go back to our baseline. So R prime, okay, we've got this cove segment with these T wave inversion, that is Brugada. That's Brugada. So for these patients, for Brugada, they need a profile for not really doing much, and then they need a cardiology consult. You want to capture these patients because, again, increased risk of sudden cardiac death. They go out and do a run, or even, sometimes even we're walking, they have potential for collapsing and dying. So this is, can't do anything, and probably either a phone call or an email or a more urgent consult with cardiology should be associated with this. All right, that's it for that lecture. Let's do a couple skills checks from last week. Critcher. Anywhere? Okay, sir. What is this rhythm? What do you think? No P waves, yep. What'd you say? A, B, or C? C? Now, good guess. However, it's not right. Why isn't it right though? What do we think about this QRS complex?
Too far apart?
Not wide. Ventricles are going to give wide, ugly QRSs, right? But this is not wide, which tells you that this is junctional. There's no P waves, and because we have a narrow complex QRS, we think about junctional rhythm that's associated with this. If we did have P waves, how might they appear? Inverted, because we have retroversion or retroverted depolarization of our atrium. So this is going to be a junctional rhythm. Okay, if we look at this specific heartbeat that is in red, Fleming. Okay, ma'am, what do you think that is?
It's obviously wide. It's also the same P wave. That makes me feel like there's something fluids embedded inside.
Okay. So no P wave, right, and wide. So even if we see a P wave inside that QRS, if it's atrial, it's going to be before, because we know the atrial depolarizing before. So the other thing I want you to look, is this occurring earlier than late or later than we think it should occur? This peaks. Occurring late, and it's wide. Late and wide. Yes. So premature or ventricular escape beat?
No, this beat.
Yes, it is. Yeah, ventricular escape beat. It's occurring later than we would think, and it is wide. And again, yes, I agree. I think there's a P wave right here on the end of it, on the back half of that. But it's not before it. If it was before it, that would be atrial, and it's too wide to be atrial, that QRS complex. Alrighty, what about this one? Right, Lake Wright. Okay, sir, what do you think about this, Pete?
Junctional escape.
Junctional escape, so no P wave. It's occurring later than we would think should, because it should occur, this next beat should be right after I'm here, okay? We're going to march this out, so, and we have no P wave, and then after that, I mean, it looks like we are SA node is back up. So we have a junctional escape beat. Narrow, no P waves. Okay, very good. Kuykendall. Okay, is that how you say it?
No.
No, not even close. Kuykendall?
It's a Kirkendall.
Kirkendall.
Yeah.
No.
I don't know, it's old Dutch, I don't know.
I'm gonna put a little curve next to it. Okay, Kirkendall. All right, ma'am, what do you think is going on in this ECG?
I think it's a first degree AV block.
I think it's a first degree AV block. If we look at that bottom rhythm strip, looks like we have narrow complex, it's pretty regular, and we've got P's and QRS's. Boy, that PR interval turns to be pretty darn long. Now, first degree, because why? Why is it first degree? Consistently prolonged. If you measure that PR interval from beat 1 to beat 6 to beat 10 to beat 20, the PR interval is going to be the same. It's consistently prolonged. All right, what about wind? Wind, Michael? Second degree Winkelbach? Okay, and why do you say that? Because what's happening? It does go with a little. Longer is dropped, must be a Winkelbach. Meaning, what's getting longer and longer and longer? Our PR intervals are getting longer and longer and longer, and then we have a P without a QRS complex. We have a P wave, so the atrial depolarization, but does not get down to the ventricles, so no QRS complex. We have a complete block, and then it goes back to our normal sign, or our conduction from our SA node, but again, we get this longer. So that is a Winkelbach, so second degree type 1 Winkelbach. All right, what about Angeli? You say that, Angeli? Premature junctional beat. Yep, premature junctional beat. Okay, so it's occurred earlier than normal, because this would be kind of out here a little bit. And no P wave. Same thing here, no P wave, so premature junctional beat. All right, now let's see another person. Ross. Okay, ma'am. What do you think is going on here? What is this? So when we look at this bottom rhythm strip, we see looks pretty regular, looks narrow. Okay, so there's that. Look at our ST segments. We come back down. We got P's. Do we have P's and Q's? Do we have Q's and no P's? What do you see? You see any T waves down there? No. And it's narrow. So if you have 0 P waves that you can see, and it's narrow, what do you think that is? Ventricular or junctional or atrial? Junctional, right? It must be junctional because it's narrow and there's no P's. If we didn't have P's, it would be inverted. So that's your indication that it is junctional. Ventricular is going to be wide. Okay, ventricular is going to be wide, and this entire rhythm is a junctional rhythm, which is very rare. Very rare. I told you guys before, it's not going to be very often you're going to see a whole junctional rhythm. Maybe myocarditis or some sort of myocardial disease can cause that. All right, a couple more. Mackenzie, Randy Mackenzie. Okay, sir, what do you think about what's going on here?
Premature atrial contraction.
Premature atrial contraction, and we know that because we have a P wave and a QRS. EQS. What else is this called? Remember? If you have a normal and then an abnormal, normal, abnormal, bigeminy. Bigeminy. A premature beat is coupled with a normal beat. That's bigeminy. If you have two prematures coupled with one normal, that's trigeminy. Okay, and then the last one, Garrison. Garrison? Okay, there you go, sir. Okay, what do you think this beat is that's circled in red? Is it wide? Okay, that's all you need to know. Say, ooh, that's ugly. Right? This is ugly. If it's ugly, it's got to be coming from where? The ventricle. Is it occurring early or is it occurring late? Is your question. Earlier, so we call that a premature ventricular contraction. PVC. PVC is what we call that. All right, perfect. Now let's go on to our next section, bundle branch blocks. Now, when we, so I do have a question for you though. Why can't you lie to cardiologists? They can always start a fib. Oh my gosh. All right, bundle branch blocks. Bundle branch blocks are still part of our rhythm. The rhythm, it takes so much time to do, right? Still part of our rhythm is bundle branch blocks. And if you don't put them into something, you're going to forget to look for bundle branch blocks. Okay? And bundle branch blocks are significant because it tells you that one or the other or both bundle branches are not conducting depolarization normally. One or both of them are blocked. So we're going to continue on with our deliberate approach to reading this ECG. First thing we're going to look at that rate. We're going to look at our rhythm. Is it regular or irregular? We've got to look at our QRS complexes, our P waves. We've got to look at our ST segments. We've got to look at our T waves. We've got to look at our PR intervals, our QT intervals, all of that. Once we do that, now we're down to looking to see if this patient has a bundle branch block. You remember that our SA node firing, when that SA node fires via Bachmann's bundle, it's going to send depolarization of the left atria, and then via the internodal pathways, it goes down to the AV node, and then down to the bundle of His, to the left bundle branch. Left bundle branch is then going to depolarize the interventricular septum, as the heart depolarizes left to right, and then we got depolarization of that right bundle branch as well. It'll come down, depolarization on the left, depolarization on the right, and then we're going to go out to reducing that out. Okay? So that's how our normal depolarization occurs. If you have a bundle branch block, one or both of those bundle branches can be blocked. Meaning, does that mean, so let's say if you have a right bundle branch block, does that mean the right ventricle doesn't depolarize? No, it still depolarizes, but just differently, right? We're no longer depolarizing via the electrical conduction pathway. Now we're depolarizing myocyte to myocyte. And what that means for you when we're depolarizing myocyte to myocyte is how does that affect the QRS complex? Why? It is wide. And sometimes, okay, depending on which block it is, you will see the difference in the depolarization from one ventricle and another ventricle. You can actually see. So normally, when the ventricle is depolarized, it's a sharp up R wave and sharp down. Okay? And that signifies depolarization of both the right and the left ventricle almost simultaneously. But when we have a block of one of those bundle branches, now we have to depolarize differently, which is at myocyte to myocyte, and we're going to see the difference on our ECG. Both right and left bundle branch are going to cause some degree of widening of that QRS complex. But the right bundle looks a little bit different, and the reason why the right bundle looks a little bit different is because, again, go back to how our heart normally depolarizes. Normally depolarizes coming down and goes left to right depolarization, right? So if you have a right bundle branch block, that right ventricle is still going to depolarize, but we're going to see it differently on the ECG. We're going to see a change in how that QRS complex looks, primarily at the top of those R waves. So we still have that wide QRS, a right bundle branch block. What can cause those? So here we know that when we have a bundle branch block on the right side, the left side is still going to depolarize normal. We still have depolarization of the interventricular receptor. We still have left ventricular depolarization. Okay, but now we've got that depolarization of the right side, myocyte to myocyte, instead of the electrical conduction pathway. Think about right ventricular hypertrophy, pulmonary embolism. Okay? If you have ischemic heart disease, even uncontrolled COPD, things that affect the right side of the heart are lung things. Lung things affect the right side of the heart. Okay, and that's why we have pulmonary embolism in here. So if someone has a significant pulmonary embolism, they could push them into having a right bundle branch block appearance on their EKG. And then some congenital heart diseases can cause this as well. On ECG, we're going to have that widened QRS. The main leads that we look for, right bundle branch block on ECG, we're going to look at one, okay, we're going to look at V1 and V6. So lead 1, V1, V6. You can see it in other leads, but those are going to be the most common leads that you see actually both left and right bundle. Okay? But those are going to be the most common leads. And one of the main appearance that tells you that this is a right bundle branch block is the appearance of R prime. R prime. Again, you might have an S R prime, but the bottom line is we're going to have two R waves. Two R waves. Just like we talked about with Brugada. Brugada is right bundle branch block appearance. So we have these two R waves that we're going to see primarily, it's most easily seen in V1. The other indicators of a bundle branch block is we get a wide or slurred S wave. Normally we go up with our R wave, down with our R wave, and back up with our S wave. But now our S wave, because we have the difference in the depolarizations of the ventricles, that S wave is going to be wider. It's going to be a little bit slurred until it goes back up to our baseline. And you can see that change in the S wave not only in lead 1, but in V6 as well. Because remember, the S wave represents depolarization of our ventricular bases. Depolarization of ventricular bases. So we have that change in the depolarization of the ventricles, that's going to be affecting our S wave. And the S wave, again, could look slurred like we see here. Okay? Like we see here, more convex. Okay? It could come up a little bit and then slur up. It could be like this. It's just wider than normal or slurred. Normally go right down and right straight back up. Okay? So we've got that R prime pattern, and then we've got the changes in our S wave. We've got lead 1, V1, and V6. We like to think of this as bunny ears, the bunny ears appearance on our ECG. Okay? And that's what I was taught many years ago, and that's still what we say. Like, is there bunny ears on that or not? And that's because that kind of represents a little bit of bunny ears. This is the ECG that has a right bundle branch block. If we look at our leads, lead 1, V1, and V6. Yes, can you see things outside of those leads? You probably can on some ECGs, but again, those are going to be the primary leads that you're looking for to say, that give you the best view, okay, of the ventricles, and tells us the best information that we can to identify if this is a bundle branch block. So in V1, first thing we're looking at, do I have RR prime? Yep, I have an R, comes down, and R again, so I have an R, SR prime. I have 2 R waves in that V1. That right there tells you, okay, there's something going on, and now I've got to think about the differentials associated with that RR prime. Okay? We've got to look and count to see if we have a wide QRS. So 1 box, 2 boxes, we're right around 3 boxes. QRS, 3 or more, that's 3 or more boxes is considered wide. Okay? And then we're going to look in lead 1 and lead 6, we're going to look for that wide S wave. Wide S wave. Because if you compare the S wave here, even if you just compare it to lead 2 kind of comes up for your R wave, down, and then maybe a tiny bit wide, but not really bad. It comes right back up. But this is wide at the bottom. Wide at the bottom. That's your indication. And V5 even looks a little bit slurred with the S wave. Main thing we're looking at, look at that RR prime. Those rabbit eaters. In V1, oftentimes you'll see it a little bit in V2 as well. If you look at that in lead 2, do we see RR prime in lead 2? No, we don't. We do see it in lead 3. Okay, so that's why I tell you to look specifically V1, okay, and then the lead 1, and then V5 or V6, because those are going to be your primary leads that you're going to identify them to. If you only look at lead 2, along the bottom, there's no indication that this is a bundle branch block. So you got to look at those other leads. Okay, left bundle branch block. Here, the right ventricle, yes ma'am.
Are you sure where you see it in lead 3? Or did you say lead 3? Can you show where you see the ears or
No. Lead 3.
Lead 3. Oh, okay.
Lead 3. See, right here at lead 3, we go up, down, and back up. Yeah. All right, left bundle branch block, right ventricle is depolarizing normally, and then the left ventricle is now depolarizing myocyte to myocyte. And the key with this is we no longer have left to right depolarization of the heart. We now have reverse depolarization. And so what that means is, if we think way back to the first lecture about where our positive and negative electrodes are at, okay, it means that this ECG machine is now going to pick up that depolarization and put it onto the ECG paper in the difference, or the opposite. Okay? It doesn't mean things are going to be inverted, but what it means is we're not going to be able to see really good depolarization of that right ventricle. We're not going to see that little R wave at the beginning. Okay? Or just this left ventricle, as it depolarizes, and the way that it gets propagated onto the ECG paper, this QRS complex gets just super wide, because that's all the ECG machine can pick up based on the reverse depolarization that's occurring. Most common causes of bundle branch, left bundle branch block: hypertension. Hypertension. Okay, yes, coronary artery disease, dilated cardiomyopathy, diabetic heart disease, even valvular disease can sometimes cause this. But hypertension is going to be the main cause of this. So you got someone that comes in, uncontrolled hypertension, things you think about, hypertrophy and bundle branch block. Okay, how might this present on an ECG? Wide, ugly, okay? Wide and ugly QRS complexes. We're looking at the same leads, lead 1, V1, and V6. Same leads for both left and right bundle branch block. What we're going to see is we're going to see this really wide QRS, okay, in V1. Oftentimes we'll see just a QS, You might see a little inflection of R, that's kind of normal, but instead of that QRS coming straight down and back up, it's going to be wide. So when we measure our QRS complex, it's going to be greater than that 3 boxes. The 3 boxes are greater. We're also going to look at lead 1 and V6 for those wide S waves. Wide S wave here and wide S wave here. Other ways that this might present, we might see a little bit of notching of our R wave. We might see a little bit of notching, so not coming all the way down and back up like we'd see with an R prime. This is just a little notch, okay? A little notch, looks like a real small M in there. We might see that. We don't see it here, okay, but this could very well just have some notching here, or comes down just a little bit and back up, and that is really consistent with the left. So wide QRS along with those wide S waves. So this is a left bundle. And you can see this certainly in V1, but really when we have a left bundle, almost every single lead that we look at is wide QRS complex. And that is your telltale sign that this is a left bundle branch block. When I look at it, the entire thing looks ugly, really. A really wide, in-your-face QRS complexes. So definitely we see that here with a little bit of an R wave. We've got our Q that comes down, QRS that comes down here, and then we've got this T wave here. Okay, here we go, wide QRS complex here. Okay, really just a wide R wave here. And we go down into our T, and then we've got a wide R wave here, comes down, okay, and then we come back up. And this is really your coming down to your S wave, coming back up, down, and then up. So diffusely wide QRS complexes. Diffusely wide QRS complexes. Some people will use this, I don't know, little rhyme, I guess, if you will, to help them try to remember left from right bundle branch blocks and what the appearance is on ECG. So those are William and Marrow. So William, the L stands for the left bundle branch and left bundle branch block. In V1, we often have this wide QRS complex, or QS, maybe a little bit of an R wave, so a little more represents like a W. And then in V6, we may have that notching of the R wave in V6, like an M would be, so that's your M for William. In a right bundle branch block, V1 is going to be more that M, that R prime wave, R prime appearance, so M for Marrow, R is your right, and then again in V6, we're going to come up, and then come down, we have that Y QRS, so that kind of represents a W. Y'all know on this day in history. 1814, Sir Francis Scott Key wrote what ultimately became the Star Spangled Banner. You guys know the history behind that? He saw, I don't know, it was in the Civil War, or War of 1812 actually, he saw this bombardment going on. And the next morning, he woke to see that the American flag was still standing. So he wrote this, it was initially a poem that ultimately became the Star Spangled Banner. In 1847, the U.S. Marines enter Mexico City. Now, a lot of you are thinking like, well, who cares, right? Well, think about the hymn, the hymn for the U.S. Marines from the halls of Montezuma. Well, that's where they went in Mexico City. Okay, they went into Mexico City at this Battle of Chapultepec, and it was considered the halls of Montezuma. That was the area of Montezuma. So that's where they started to get their hymn from. Okay, so did anybody watch the Emmys last night? In between your farm tests, well, the Emmys last night actually did a tribute to the Golden Girls. And the Golden Girls theme song was, "Thank You for Being a Friend." And then 2020 largest one-day increase in COVID cases. Now, I don't really specifically care about the numbers. The reason why I bring this up is because this. Do you guys know currently what the CDC guidelines are if you have COVID?
No.
You can go to work. Go to work. Stop coming into the emergency department. Go to work. The only thing the CDC says is this. If you have a fever, the recommendation is you do not go to work until you are fever-free for 24 hours without medication. And although you don't care about that now, it's going to be super important when you go out and you educate your patients on this kind of stuff. So you've got to stay up with the current recommendations based on current guidelines, right? So ultimately people can go to work. They recommend wear the mask for 5 days. If they have a fever, should be fever-free for 24 hours. All right, let's take a break. I want you to look at our rate. We finish all the steps associated with our rhythm, including looking at our breath. The next thing we're going to do is axis. We have rate, then we have rhythm, then we have axis. Remember that the normal axis goes from here at the top right down to the left. That's our normal cardiac axis based on the pull of the left ventricle. Okay, so our electrical conduction is going to go still from the SA node down to the AV node, down to the bundle of His. But our pull, because that left ventricle is so big, is going to be toward down into the left. That's our normal cardiac axis. So then you have to think about things that can change that cardiac axis. Things like ventricular hypertrophy. So if your left ventricle is really big, is it going to pull that electrical vector more left, or is the electrical vector going to go more towards the right? It's going to go more towards the left, right? Because now you have even more electrical conduction being pulled. You have even more electrical energy being produced because now that left ventricle is super big. What about if instead you had left ventricular hypertrophy? What if you had a lateral infarct? So lateral infarct, which is lead 1, AVL, V5, V6, those look at the left side of the heart. And let's say you had an infarct identified in those leads. So that's the left side of the heart. If that piece of tissue, that piece of heart is infarcted, that means it's what? Dead. Okay. So now how is that going to change your electrical axis?
The right.
It's going to go more towards the right. Okay. It may still be in normal range, okay, but your electrical axis numbers are going to be different. They're going to be different. That's your identifying factor that there's something that's changing this electrical axis. We got to figure out why the electrical axis is changing. So our normal electrical axis, so if we look at this on this hexaxial, what's called a hexaxial system, our normal electrical axis is going to be from positive 90 right here, all the way through to negative 30. So from down here in our inferior leads, okay, to our lateral leads, AVF, all the way up to AVL. This is going to be our normal axis. So when we're looking at that in degrees, plus 90 to negative 30, let's consider our normal axis, normal degree. If someone has a left axis deviation, maybe that left ventricular hypertrophy is pulling that electrical conduction even more to the left, then their degrees are going to be negative 30 to negative 90. If instead we have an infarct over here on the left side, and we now, our right ventricle is now pulling more electrical activity over towards the right side, our numbers will be from positive 90 to 180, right here, 90 to 180. And then if something really crazy is going on with our heart, okay, we have something called extreme right axis deviation, which means that instead of our electrical conduction coming down into the left, something's pushing it all the way back up this way. Something is causing the EKG machine to read everything truly in reverse way. Now we have depolarization that appears to be going back up this way. And oftentimes, you have extreme right axis deviation, either something really, really bad is going like VTAC, okay? Or you can see it like in a pace rhythm, or limb lead reversal. What can cause left axis deviation? LVH would be one of the most common things. Inferior MI can cause it. A left bundle branch can cause this as well. Left axis deviation, meaning that we're having our electrical conduction is being pulled even more to the left. It's going to be the upper portion of that left axis, that hexaxial ring. Right axis deviation, right ventricular hypertrophy, pulmonary embolism, COPD, pulmonary hypertension. So things that affect the right side of the heart are things that affect the lungs. That can affect that, and that can cause right axis deviation. Extreme right axis deviation, limb lead reversal. So that would be the number one cause. Again, VTAC. If they have hyperkalemia, and we can see extreme right axis deviation, COPD, and then a lot of times if someone has a pacemaker in, or being V-paced, a lot of times they will have extreme right axis deviation. We're going to first talk about how to identify the cardiac axis in the frontal plane. So if I say this is the frontal plane, what leads are we using? Our limb leads. Our limb leads is what we're using. And specifically, we've got, again, two and a possible. So we've got two leads we're definitely looking at, which is lead 1 and AVF, and that possible is lead 2. And here's the reason why we have a possible. All right. So the way that this is actually set up, we talked about our normal axis coming from here, positive 90, all the way up to a negative 30. Okay? But the way that they set this up is they set this up in this, to make it easier, in equal parts of 4. The problem is the heart axis is not equal parts of 4. That left axis, okay, takes up part of this, or I'm sorry, the normal axis here, on this one, the normal axis would end here. But that normal axis actually takes part of this left axis up here, because it goes all the way up here to negative 30. So if someone has a left axis deviation, we've got to identify if it's a true left axis deviation, or if it's kind of borderline, meaning it's from that 0 to negative 30, which would still indicate a normal axis. So the first thing we have to do, because we're going to set this up in quadrant methods, the first thing we have to do is we have to identify what quadrant we're in. Are we in the normal quadrant? Are we in the left axis quadrant? Are we in the right axis quadrant? Are we in the extreme right axis quadrant? That's the number one step. So what we're going to do is we're going to look at the R waves in lead 1, and we're going to look at the R waves in lead AVF. R waves in 1 and R waves in AVF. If in 1, so then the way that I teach this, and you can learn it any way you want, but when I teach this, I teach people this by using their hands. So lead 1 is going to be our thumb in our left hand. And lead AVF is going to be our thumb in our right hand. 1 AVF, 1 AVF. Okay. If both of the R waves, so we're looking at lead 1, and we're looking at lead AVF, and we're looking at the R waves, the QRS complex, the R wave of that, and we're going to see, is it more upright than down going? What is our R wave, what does our QRS complex look like? Is it more upright or is it more down going? Okay. If lead 1 has an upright QRS and AVF has an upright QRS, we're good to go. We are normal axis. If lead 1 has an upright and ABS, the QRS complex is upright, that's normal axis. Okay? If instead, in our lead 1, if we have positive QRS complex, but ABF, our QRS complex is down going, meaning it's more negative than it is positive, okay, we have a, going with our positive thumb, we have a left axis deviation. Okay? If instead, looking at ABF and lead 1, ABF is up, but lead 1 is more negative, we're going with our positive thumb, we have a right axis deviation. Okay? So 2 thumbs up, normal axis. Okay? 2 thumbs up, normal axis. If my right thumb is up and my left thumb, so right thumb is what? ABF. Left thumb is lead 1. My right thumb is up, so meaning my QS complex is more positive than it is negative. And then in lead 1, it is more negative, then what axis do we have? Right axis deviation, because my positive thumb is being right axis. Okay? If we have in our lead 1 is positive, our lead ABF is more negative, we have a left axis deviation because we go on our positive thumb. Okay, so that's the first thing we gotta do. We gotta find our quadrant. Which quadrant are we in? Knowing in our mind that the heart is not separated equally to all these quadrants. The first thing you can do is identify the quadrant. We've got to know where to look. Okay, where we're going to even begin, and that's how we begin with our finding that quadrant. The next thing you do, only if we have a pattern that suggests left axis deviation. So everybody show me what a pattern of left axis deviation would be. Left thumb is up, right thumb is down. Left axis deviation. Only if you have left axis deviation, now we have to determine is this a true left axis deviation, or is my normal axis at 0 to 30 is actually representing a normal axis, but we're going up towards that left axis. So if we have left axis deviation, we're going to look at lead 2. The only time we look at lead 2 is if we have left axis deviation. We're going to look at lead 2. If lead 2 is more positive than it is negative, this is still that normal axis from 0 to 30. It's still in that normal axis realm. If lead 2 is negative, that means it's the true left axis deviation. Okay. So again, if I have left axis deviation, upright in 1 and down going in ABF. My QRS complex is more positive in 1 and it's more negative in ABF. That gives me a left axis deviation. If I have that, only if I have that, do I look at lead 2. When I look at lead 2, if lead 2 is more positive than negative, I'm in the normal axis realm, which is at 0 to 30. If my lead 2 is negative, that pushes me all the way up. I'm somewhere between, my axis is somewhere between negative 30 and negative 90, and I have a true left axis deviation. So step 1, figure out your quadrant. Step 2, if you have a left axis deviation, you're going to look at lead 2 and determine, is this a true left axis because my lead 2 is more negative than positive, or is this still normal axis? Right? Because I have a lead 2 is more positive than negative. That's a normal axis between 0 and negative 30. Okay, that's step 2 if you have left axis deviation. Okay? The next step, step 3. Okay? So if I did not have left axis deviation, then I'm going right to my step 3. Step 3, you must find what we call the isoelectric lead, or the smallest QRS complex only in your limb leads. Any of your limb leads. Lead 1, 2, 3, AVR, AVL, AVF. Only those leads, those are only leads we're looking at right now. I'm going to find the one that has the smallest QRS complex, or the one that's most isoelectric, meaning it goes up above the baseline and down below the baseline the same. And the purpose of this isoelectric lead, okay, is to help us identify the number that's associated with our axis. So if I look at this first ECG on the left, okay, this first ECG on the left, which one of these would we say was either our smallest QRS complex or our isoelectric lead? Which lead? AVF, right? So if we count the boxes above and below baseline, okay, this is the smallest and happens to be also isoelectric. I mean, if you count it above and below baseline, it looks about the same above and below. But it's also the smallest QRS complex. So we've got our smallest QRS complex right here. So let's look at this. If we look at this same ECG, what quadrant is our axis in? Well, what is 1?
Positive.
1's up, okay? And then AVF, okay? AVF is kind of like this, right? AVF is kind of like this. So what we know is this, okay? We know that we're not necessarily in the normal because we're not both upright, okay? We're not necessarily, what would this give us?
Left leaning.
Left axis, right? So we're somewhere between. So that tells us that we're nearing that left axis, okay? We're nearing that left axis. So the first thing we do is we identify the quadrant, okay? If we're left axis, then we're going to look at lead 2, and this lead 2 is upright, okay? So that tells us that we're right on that border somewhere, that left and right axis, or left axis and normal axis. Okay, let's look at this other ECG. In this other ECG here, what would you say is either your most isoelectric or your smallest QRS lead? AVR. Does everybody agree with that? AVR, if you were to count the boxes above and below, because this is pretty deep, this is pretty tall, okay, this looks isoelectric, but it's not the smallest, okay, so AVR. Everybody agrees that it's AVR, all right? So when we look at our quadrant, what quadrant are we in?
Right.
So we're down in 1, and we are up in AVF, which gives us our right axis deviation. Our quadrant is going to be right. So we don't have to look at lead 2. We don't have to look at lead 2 because we're not left axis. We don't even have, like, we're kind of like borderline. No, we are definitely right axis. We're completely opposite of left axis. So this is our smallest QRS complex, so that would be our third step. First thing is identify the quadrant you're in. If you're left axis deviation, now you've got to look at lead 2. If you're not, the next thing you're going to do is this is step 2, is identifying the smallest QRS in your limb leads only. Okay, so now, step 4. We've identified the quadrant. We've identified if it's left axis deviation or not. And so we looked at lead 2 to tell us, is this truly left axis or is this in the normal axis realm? The next thing we have to do is we have to identify something called the isoelectric partner. Isoelectric partner. So what this does is this is a hex axial, meaning you've got degrees that are associated with each lead. We've got degrees that are associated with each lead. We've got AVF. AVF comes here positive 90, but AVF goes all the way through. Okay, all the way through. And then lead 2, positive 60, all the way through to 120. AVR, positive 30, 150. So we've got these leads that are associated with these specific numbers. So the first thing we're going to identify is what quadrant we're going to be working in. Are we going to be in the right axis, normal axis, left axis, or extreme right axis? Once we identify the quadrant, okay, and we identify the smallest lead, now we can identify what number that's going to point to. If I tell you on an ECG that the QRS complex is more negative in lead 1, okay, and more positive in ABF, and more negative in one, more positive in ABF, where are we at? Right axis. Okay, so we're going to be down here somewhere. Okay, and if I tell you that the isoelectric lead, meaning the smallest QRS complex, is AVR. We're going to look at this hexaction and we say, okay, where's AVR? Well, here's AVR, right here. All right, everybody see that? That's AVR. So far we've identified that we're in the right axis quadrant. We've identified that it's not left axis, we don't have to worry about lead 2. Our smallest QRS is AVR. So we're going to find that AVR, we say, okay, I've got my line on AVR. We've got to find the lead that is perpendicular to AVR, and that lead, that's going to point to what your number is, your specific right axis deviation at negative 30. Okay? Or I'm sorry, positive 120. Right axis deviation at positive 150. Okay? So our AVR is here. What lead is perpendicular to AVR? Lead 3. So perpendicular 90 degrees to AVR is lead 3. We know if we looked at lead 3 comes all the way through here. How do I know that my number is not negative 60? How do I know that? Because we're in the right axis. We're in the right side. That's why you must find the quadrant first. If you don't find what quadrant you're in first, you don't know which way to go. Am I going to be up here in up here my negatives, okay, negative 60, or am I going to be here in my positives? Okay, that's why you have to find the quadrant first. And we find the quadrant first by looking at lead 1 and lead AVF. That tells us what quadrant we're in. Once we identify that quadrant, we look at the smallest lead. Okay, that smallest lead is our main line, and then we go perpendicular to that smallest lead. All right.
What is the purpose of finding that out?
What is the purpose? So if you have somebody that comes in and they say, no, I'm completely healthy, and you look at it and you say, okay, well, what are you here for? Oh, I just need a routine check. Okay, part of my routine check of EKG. Okay? And you look at that EKG and they have right axis deviation, they ain't okay. Why? Why would they not have normal axis? If they are completely healthy, why is something pulling their electrical axis over to the right? Okay? So it tells you not anything necessarily acutely, okay? But it tells you underlying pathology. And it makes you think to yourself, what's causing this change? What is causing this person to have a left axis? In the setting of, I'm completely healthy, but oh, your blood pressure's a little high today. Is it always high? No, I don't think so. When's the last time you seen the doctor? Oh, about 15 years ago, because I'm completely healthy. But I have left axis deviation. I bet you that you have long-standing hypertension. And now we have this. This axis change is typically, not always, but typically evidence of significant or chronic underlying disease. Okay? All right. So we'll do a couple of skills checks. You've got this person that has this ECG right here. We are up in 1. And we've got this AVF that's kind of neither up or down. Okay, we're going to say it's but that's AVS and not the up or down. So we know we were up here. Okay, we know we're kind of this here, right, for our AVF. Our AVF is like this. Okay. And so we know it's not normal, but we also know maybe it's not really left, so we're kind of in between there. All right, but if we say like, all right, well, I don't know, maybe this is a little bit more up and down, we know we're kind of at the borderline normal. Okay. Either way, if you look at lead 2, you know lead 2 is upright. So you're not going into that left axis area. Okay? And when we look at this, what do we say? We said that AVF is our smallest QRS, right? So then we look here at AVF. AVF is here. We know that we're going to be somewhere over here based on looking at the quadrant of V1 and ABF. We're going to be somewhere over here. ABF is our isoelectric lead, and then our isoelectric partner is going to be lead 1. Okay? And one way that I look at this is I know that the way that I can remember my isoelectric partner is because it goes like this. 1, ABF, ABR, V3, and then 2 and ABL. So it goes criss, cross, straight. Criss, cross, straight. That's how you know those are your isoelectric leads and isoelectric partners. So if we have our isoelectric lead as ABF and we come across here for our isoelectric partner, we know we're not over here at positive 80, so then that gives us an axis of 0 degrees. So it's a normal axis at 0 degrees. Normal axis at 0 degrees. What about this next one? Okay, if we work through this, would everybody say this is upright or down going?
Down.
Down going in 1. What about ABF?
Up.
Up. So we have a
Right lean.
right axis deviation. So we're in the right side somewhere. Okay, and then our isoelectric lead is
ABR.
ABR. So this is our isoelectric lead. We got to find our isoelectric partner, which we will know is lead 3. You can come down here, isoelectric partner. And I say that because inevitably on the exam, people can't determine what's 90 degrees. Like, this is 90, but when you're looking at it on the exam, and you've got the small, picture, like this can't figure out 90 degrees. So they'll choose something that's completely not 90 degrees. Yes?
So on the exam, we're going to get a picture of that circle, by chance? Like,
Yes.
okay. I was making sure we didn't have to like memorize the.
You do not have to memorize the circle. Because in real life, you don't have to memorize the circle. I know about real life stuff. Okay? So in real life, you should have an axial wheel. You don't have to memorize those numbers associated. I'm going to give you those because in real life, you're going to have that. And if you don't, it's your own fault. Because you should have it. You have that tool. All right. So what we said ABR, and then we're going to go to our isoelectric partner, which is lead 3, and we're at positive 120. Positive 120. So something is pushing this patient over to the right axis. Okay. That is axis in our frontal plane. Axis in our frontal plane. We can also, and should also, determine axis in the horizontal plane. So if I tell you horizontal plane, what leads are we using?
V1 through 6.
V1 through V6 are precordial leads, aka chest leads. All right, so precordial leads help us determine our horizontal axis. Remember, in our precordial leads, our normal R to S wave progression is small or almost non-existent R wave in V1 with a large S wave, V2, a little bit of an R wave, still large S wave. Around V3, V4, we're going to start to transition to more prominent R wave and less prominent S wave. That is normal. Okay, that's our normal transition in a normal person that does not have a problem with their cardiac access. So if someone has poor R wave progression, we call that a clockwise rotation of the axis. If they have poor R wave progression, meaning, okay, V1, I don't have an R wave, I don't expect necessarily to see an R wave in V1. V2, I would normally expect a little bit of an R wave. Okay? I would normally expect a little bit of an R wave. And then I go all the way down to V3 and I still have no R wave. That's unusual. I should have an R wave by the time I get to V3. Matter of fact, even for this one, I go to V4, I still don't have an R wave. I have all these dominant S waves. That's poor R wave progression. They're not seeing R waves around that V2 and definitely in V3 area like we should. A poor R wave progression, it can be normal, it can be, but we want to think about things that can cause this to happen. Something like an anterior infarct left ventricular hypertrophy. Okay, so what we think about an anterior infarct is that the anterior portion of the heart, so V3, V4, we have dead tissue. So now that electrical vector is now being pulled more what? Posteriorly. We're going to see that in that V1, V2, V3, V4. Here we don't see those R-wave progressions. Cardiomyopathy, left bundle branch blocks, all of those can cause this poor R-wave progression or clockwise rotation of our axis. Okay, so then we can have counterclockwise rotation of our axis, meaning we have a prominent R wave in V1. We've talked about several things that cause prominent R waves in V1. Those need to be on your differentials when you see a prominent R wave in V1. Okay, from here on out, they need to be on your differentials. You've got to start creating differentials for different things as you progress through the rest of phase 1 and then into phase 2 and then from then on. So things that can cause poor R things that can cause a reversal of your R wave. Okay, do you guys remember anything that we talked about that caused reversal of the R wave so far? Bundle branch. Okay. Brugada. So Brugada, you might have that. STEMI? No, we haven't talked about that yet. So you got to think about. So what do we have? We haven't talked about hypertrophy yet. Okay? We haven't talked about ischemic heart disease, posterior. We talked about something that might cause reverse of that. Another topic. But things that can cause this to happen, things that can cause a more prominent R wave. And again, things that can, so if you have a posterior MI is going to push things more anteriorly. The anterior is going to have more electrical induction. So now we're going to see those R waves more prominently. Did we talk about bundle branch block? Yes, we said that, right? Bundle branch block can cause a reverse.
Left. The left bundle branch?
Left bundle. All right, so let's do a couple of skills checks. We got a few more minutes. We need these skills checks. We do. I promise you. Okay. So the first thing that we want to do is find the quadrant. Find the quadrant. So in this, what is our quadrant?
Right.
Right axis. Somewhere in the right, so we have some right axis deviation. Somewhere down in that right quadrant is our first thing we're going to do. So because this was not left axis, we do not need to look at lead 2. We're going to skip to the next step. The next step is, once you find the quadrant, you're going to look for the smallest QRS complex in your limb leads. Smallest QRS complex.
The ABF?
Does everybody think AVL? AVL. Okay. So let's go with AVL. So we have got our, we know we're down here somewhere down here, right? Somewhere in the right axis because we already found our quadrant. We say AVL, there's our smallest lead. Okay, so then we look at AVL. This comes all the way through AVL. Okay, what is isoelectric to AVL?
Negative 120.
Well, no, remember, we're not there yet.
Positive 60.
We've got to figure out what's 90 degrees. So what's our isoelectric lead to AVL?
Positive 90.
Lead 2. Lead 2 is isoelectric to AVL. So where is lead 2 at?
Positive 60.
Right here. Okay. So, does anybody see a problem?
Yeah.
Yeah, we see a problem. And we see a problem. That, if we say AVL is our smallest, we're not even in the right quadrant. It doesn't take us to the right quadrant, which means that's not the right lead. That's not our most isoelectric or smallest lead.
Is it ABF?
So we look at AVL. So we look at AVL. ABF because those are the ones that's going to be between those two, right? ABR, ABL, or ABL and ABF. So what is our, so ABF is our isoelectric. What is 90 degrees to ABF? Lead 1. So where are we at?
-180.
180. So technically AB in that right axis is going to be a positive 180. Technically, and then the extreme right axis will be negative 180. Okay? So that's a way to double check yourself as well. Like, wait a minute, how if I measure the, if you had calipers, you could measure it, or you could take a piece of paper and put it on the top of the arm wave, bottom of the S, okay, and say, look, all right, if I work this out through ABL, well, that doesn't make any sense. And the fact that you guys picked up on that tells me that as much as you don't think you learned anything today, you learned a little bit because you're like, that doesn't make any sense. That doesn't take me to my quadrant. I gotta be in my quadrant, which is why you have to find the quadrant first. You have to find the quadrant first. So 180 is going to be our degree. All right, let's look at this one. What do we think about this one? What quadrant are we in? Left. Okay. If we're in our left axis degree quadrant, what's the next step?
You look at lead 2.
Look at lead 2. Okay?
Isoelectric.
What do we think about lead 2?
Isoelectric, but it's also the smallest.
Well, so what is our baseline of our ECG? PR segment. Okay. We have our PR segment. So our PR segment's here. Okay. How many boxes do we have below our PR segment?
1.
Yeah, maybe 2. How many boxes do we have above our PR segment?
5.
More. The problem that you have is we have ST or J point elevation, right? So it makes it look wonky. But if you really look at your baseline, then we would say that this is really more upright than it is down going, which means what? We're in a normal axis area. We're in a normal axis area. So left axis deviation, look at lead 2. If it's more positive, that brings us back to our normal axis area. Okay, what is our isoelectric lead, or smallest QRS?
2.
Happens to be lead 2. Okay, what is the partner to lead 2? ABL. So lead 2 comes all the way up here. We know that we're somewhere in that normal axis. And we come up to ABL. So what does that give us?
-30.
-30. So we're right on that. Okay, but we're still in the normal axis. So it'll still be normal axis at a -30. Normal axis at a negative. Can you believe I used to teach this all the way down to the 10 degrees? By the end of that class, it was terrible. Really, really terrible. You're like, oh my God. But it's cool to know how to do it. It's just not that much fun. Okay. So -30. Okay, what do we have here? What do we start off with our quadrant? What quadrant are we in? Normal, right? We love, man, it's normal. We love that. That makes it a lot easier. Okay, what's our smallest lead?
ABL.
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 Okay. ABL. Okay, well, let's see. We know we're in normal axis. Let's go with ABL. Let's just try ABL. Let's see what we got. If we say ABL, where is our isoelectric partner to ABL? Lead 2 coming straight across. So ABL, lead 2. Does that put us in the right quadrant?
Yes.
What is our answer?
Positive.
Positive 60, right? Positive 60. So if we take, someone said, does it work with 3? Well, let's look at 3. 3's here, right? What's isoelectric to 3? I mean, the partner to 3? ABR. So we've got lead 3.
Okay.
Okay, where's ABR at? Right here? Okay. Does it work with lead 3?
Yeah.
It's still a normal quadrant. So either one, huh?
For Texas purposes.
Oh, I wouldn't think, I wouldn't think. No, that'd be pretty obvious, yeah. So in real life, like, okay, we're still in normal axis. Now, what would be important though is, I saw this patient 5 years ago, or 3 years ago, and that 3 years ago, that person had an normal axis at positive 60. I'm seeing them now, and EKG tells me they've now got a normal axis at positive 30. Something is causing that shift. What is not being controlled well? Something underlying pathology. And that's the whole point, is to try to do preventive medicine instead of reactive medicine. And we can do that by identifying these things on the ECG that say something's not right, and we need to figure out what it is to help prevent additional progression and worsening of that underlying disorder. Probably uncontrolled hypertension or poorly controlled hypertension. I take my medicine when I feel bad. All right, what do we have here? What do we think about this axis, or this, what quadrant are we in?
Right.
So we are down? I'm sorry, we're down, up, right? So down, up, which is?
Right.
Okay, right. And so right, we're going to be down here somewhere. Smallest QRS?
ABR.
Looks to be ABR right here. I mean, one is small too, but ABR definitely seems to be the smallest. So we're down here. We've got our ABR. So ABR is located here. What is the isoelectric partner to ABR?
3.
Lead 3, if we come diagonal down, lead 3, and then we have this here. So that gives us a right axis deviation at positive 120. COPD, underlying cardiac or underlying pulmonary disease, is going to start pulling that axis over. Probably have a degree of RVH in here as well. Okay, what about this person? Poorly controlled hypertension. Okay, what is our quadrant? Okay, true left?
True.
Or normal? True left, right? Because we have left, and then we're looking at lead 2. Lead 2 is more negative than it is positive, but that means we truly have a left axis deviation. What is our smallest QRS? AVR. So we're going to come here, AVR. We know we're in the left axis area, so we're not coming down here. We're doing AVR. We're going to do our isoelectric partner from AVR is lead 3, coming all the way through. But again, we're not down here, so we know we have to be up here, which gives us left axis deviation at a negative 60. Shoo! We made it. All right. See you tomorrow.